Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Again, welcome everybody to today's program, an update on what you should know about cardio-oncology. With Dr. Jones and Dr. Medepalli, we're happy to offer this program again. We had a great response to the last one, so we're happy to do this again with some updates. I'm Katie Armsby, Program Outreach Director with Cancer Support Community Atlanta. We encourage you to visit our website, cscatlanta.org, where you can see a complete list of the oncology support programs offered. We have some great support groups led by licensed mental health professionals, stress reduction classes like yoga, Tai Chi, a monthly nutrition seminar led by an oncology dietitian with Northside Hospital Cancer Institute. We also do a live cooking demo here at Cancer Support Community Atlanta, and of course, education programs like these. So please visit our website where again you can see all the programs offered, and we also are now offering in-person programs too. So we encourage you to join us here in person. I'm happy to welcome Dr. Jones back to this virtual platform. She has been so kind to do many of these programs for us, and we're so grateful. Dr. Cheryl Jones is board certified in internal medicine and medical oncology. She completed her residency and fellowship at the Medical College of Virginia in Richmond, Virginia. Dr. Jones serves as president of Georgia Cancer Specialists affiliated with Northside Hospital Cancer Institute, where she practices in the Macon location. Dr. Jones is active in local and state medical organizations and has served as president of Bibb County Medical Society, as well as serving on the board of directors for Medical Association of Georgia, the Middle Georgia Education Foundation, the Georgia Physicians for Accountable Care, the Middle Georgia affiliate of the Susan G. Komen Foundation, the American Cancer Society in Daugherty and Bibb counties, and the state of Georgia. So with that, Dr. Jones, I will pass it off to you.
Thank you. It's my privilege to be able to introduce this topic during the month of February, which is Heart Awareness Month. Dr. Medepalli, who's a board-certified cardio-oncologist and actually the medical director of Northside Hospital Cardio-Oncology program. She brings 20 years of experience to her practice with clinical interest in non-invasive cardiology, women's heart health, and cardio-oncology. She's an active member of the local community, promoting women's heart health awareness and the detection of heart disease through a combination of speaking engagements and editorial content. Her passion for cardio-oncology has extended to her current work in developing the specialized cardio-oncology program here at Northside Hospital and to address the cardiovascular needs of all patients with cancers. She's already authored many publications over the years on cardiovascular disease, cardiovascular imaging, and specifically in her specialty of cardio-oncology. When she's not working, you can find her traveling to new places with her family, playing the violin, practicing Zumba, and even hanging out with their friends. So Dr. Medepalli, I'm going to turn this exciting program over to you to discuss what cardio-oncology is, our latest updates, and the program here at Northside Hospital. Thank you.
Thank you so much, Cheryl, for that intro. First of all, I want to also thank Katie and Cancer CSC Atlanta for giving me this great opportunity to raise awareness of cardio-oncology for our cancer patients. What is cardio-oncology? You know, people might not have heard much about this, but it is an emerging field now with so many survivors and survivorship increasing and wonderful care and research from our oncology colleagues. The taking care of oncology patients for their cardiovascular needs that's where cardio-oncology started. Why is it important, and where can people go to learn more about the cardio-oncology program at Northside Hospital? These are the few things I would like to address in the next 30-40 minutes. What is cardio-oncology? Cardio-oncology is a specialized field, and it's mainly to address the cardiovascular needs of patients with cancer and cancer survivors to optimize their care in a multidisciplinary approach. Multidisciplinary in the sense not just cardiologists are involved, cardiologists, oncologists, pharmacists, nurse practitioners, radiation oncologists, surgeons, and several other disciplines are involved in this field of cardio-oncology. Why is cardio-oncology important? The United States National Cancer Institute, NCI, estimated that there were close to 14 million survivors who are alive in the United States in 2012, and this is rapidly growing. And by 2032, it is projected that there will be at least 23 million or more survivors in the United States. 69% of adults diagnosed with cancer lived 5 years, 5+ years since diagnosis. That is wonderful news for survivorship. Before, the cancer survivorship is so low, so people didn't even live longer to see the cardiovascular side effects and potential toxicities of risk factors getting much more because of their dealing with cancer and can't keep up with their cardiovascular health or comorbidities. They didn't see that. Now more and more patients are surviving with excellent care and research and new meds and immunotherapy and all these available modalities, therapeutics for their cancer care. They're surviving longer, and now we are seeing more and more cardiovascular downstream effect, health being compromised. So that's one of the reasons why we are seeing more and more need for cardiovascular care for our oncology patients. Cancer therapies, including radiation therapy, not only chemotherapy, can cause cardiovascular complications. Advances in treatment have led to improved survival of patients with cancer, but treatment side effects may have negative cardiotoxic effects. And as cardio-oncologists, we comprehensively assess the cardiovascular health of our patients, not only during treatment, but we try to see before treatment for a few subgroup of patients who need intensified optimization of their cardiovascular death so that their oncology treatment will be ongoing, uninterrupted, and they become survivor with no cardiovascular complication. That is the goal of our cardio-oncology multidisciplinary team. So if we look at the picture is worth 100 words, and if you look at the survivorship, this part of the graph shows how many cancer patients in U.S. population in millions. Patients in cancer and right now with cancer are also increasing, but the survivorship is going up. In 2040, estimated that 26 million survivors will be in United States itself. And this is why, because if we look at the drugs and the new therapeutics, which are in active research in oncology care, when compared to other systems, for example, me being a cardiologist here is a cardiovascular drugs in trials, whereas oncology drugs in trials exponentially increasing. So a lot more cancer therapeutics are available for our patients to survive that cancer and successfully come out of the cancer as a survivor, or if they still have metastatic cancer, they're living longer with ongoing cancer with good quality, a reasonable quality of life. So why is cancer and cardiovascular disease, both, what is the reason why both are hitting? Why not infectious disease or something else happening? If we look at the cardiovascular disease and cancer, top 2 causes of death based on the data, this is the latest statistics which came out in 2021, looking at all the death certificates in United States for every 100,000. You might have all noticed that COVID-19 is taking its way up. That was in 2021. It's now slowed down, but it emerged as the third leading cause of death. But still, heart disease and cancer were number 1 and number 2 cause of death in United States. And if you look at 2020 and 2021, unfortunately, heart disease increased. We went in reverse direction, and cancer-related deaths also increased. Both increased in 2020 and 2021. This is the numbers, the latest statistics as of deaths per 100,000 recently published. So the top two, if we look at the cardiovascular disease, when does that prevalence increase? When do the patients, when they're at 40, 50, 20, 30? So if you look at when they get to 60 to 79, that's when we see the cardiovascular disease, rapidly increasing. And when we look at the cancer statistics, we look at the men suffering with prostate number 1 cancer and women with the breast cancer. If we look at the age, the peak age where they see is 60s again. So 60 is the magic number when the cardiovascular disease is hitting, cancer is hitting at the same time, the prevalence is high, and all our risk factors also go up when women get to menopausal age, and men also in their 45 to 50 range, the risk factors steeply increase. So all are coming at the same time. So heart disease, to summarize, heart disease and cancer are 2 leading causes of death in the United States. They share several risk factors. The risk factors for cancer are also risk factors for cardiovascular disease and the age at the same time. So advances in treatment with oncology care therapeutics may have their own cardiotoxic side effects, or patients living through the cancer may be paying less attention to their cardiovascular needs going through the cancer and associated demands, or they may have underlying cardiovascular disease which get exacerbated during the cancer stress. So there are several things which play a role. Hence, we need to be cognizant of this around the cancer, all these things happening, and control. So patients come out of the cancer successfully and with less cardiovascular side effects. So not only during cancer we extend the care to survivorship because of late onset cardiovascular complications. So as cardio-oncologists, we aim and do is comprehensively assess the cardiovascular health, not only before the treatment to optimize the management of pre-existing cardiovascular disease like valvular heart disease or prior stents or prior heart failure, and decrease the complications during the cancer care. So our oncologists can try to not to hold the chemotherapy as little as possible. Last thing you want to hear is my cancer is responding very well with all the treatment given by Dr. Jones or other oncologists, but now the treatment has to be stopped because the heart function dropped. We see it all the time. We used to see it all the time, but not now anymore with cardio-oncology and the cardiology and more awareness. The patients and the oncologists taking care of around the patient oncology, people are, patients are continuing their cancer therapeutics without interruption and successfully. And we want to take that cardiovascular complication limitation even late into survivorship. So cancer survivorship and risk, if we look at the data, there's a large study which came out in 2009 where cancer survivor study, it's a retrospective, they look back study where they compared the survivors of pediatric cancer with their siblings. They looked at the patient and the survivor and the sibling who didn't have cancer, compared the sibling and the pediatric cancer survivor. the pediatric cancer survivor had 15-fold increase of lifetime risk, not only of heart failure combined together, heart failure, hypertension, or cardiovascular risks, 15-fold increase. So this is head-to-head, same environment, same kind of, like both siblings are in the same environment, but the survivors have higher risk, especially who had undergone the anthracycline-based chemotherapy or for their lymphomas and other oncology mediastinum, that is the chest radiotherapy, because heart is in the way. In older patients, if we see, then as we talked before, as I said before, as we get to 50, menopause hits in, abdominal obesity sets into women, the number of steps they take goes down, and triglycerides go up, and all the risk factors of with menopause sets in, obesity sets in, and all these risk factors come in, and at the same time the cancer is also coming in, and the cancer related chemotherapy is coming in. So all these have increased the incidence of clinical heart failure at 5 years when you look at 5 years. So that's why we at Northside Hospital, last task force meeting, myself, Cheryl, and several others involved, are developing, we started developing survivorship protocols to have a standardized care delivery across the Northside system. And that way we can take care of our survivors as well. The three main protocols we're working on is mainly people who were exposed to anthracycline in their pediatric age group or older patients, or if they received chest radiation or abdominal radiation or neck radiation, or who received allogenic bone marrow transplant. These three are very high-risk group to get these kind of lifetime risk increase compared to their matched controlled group. So just a very good picture I found while I was preparing for this lecture is this: if we have this cancer treatment coming in to a patient, that depends on the reserve. It's like bank account. If you keep on draining the bank account, it's zero. So if we drain the bank account with all these prior cardiovascular disease, valve disease, heart failure, they have a high blood pressure, high cholesterol, smoking, decreased activity, not good diet, hypertension, and all these things are happening. All these things are around the reserve is draining. So that's why the cancer treatment has less reserve to go through, not only chemotherapy, radiotherapy, targeted tumor, and associated side effects. So as a cardio-oncologist, our main goal is to take care of all these factors and optimize what we call as cardioprotective therapy, optimize the medications which have shown in consensus statements and trials had shown to benefit our oncology patients to improve their cardiovascular health and prevent complications. And if we look at the simple graph where survival probability, 8 years is if the patient had a breast cancer and she had survived 8 years, the chances of that patient having cardiovascular death is more from cardiovascular death than the recurrence of cancer. That's what it showed. 8 years, if you see, look, if they survived 8 years or more, the risk of cancer is less compared to risk of cardiovascular disease hitting them. So if you look at cancer survivor without cardiovascular disease, they survive longer, whereas cancer survivors with cardiovascular disease, their survival goes down. Around 8 years is the point where usually they break even. So the point here I also wanted to make is not, okay, I survived the cancer, I don't have any cardiovascular complications, I'm done, I'm good, I'll ring the bell and that's it. No, because usually the complications from radiotherapy and anthracycline, not necessarily right away, they show up in radiotherapy especially, they show up with valvular heart disease or any other complications if they may have to, usually after 5 years. So that is why we we stress on the survivorship, not only before, during, but also after the cancer care, that they need to be know their numbers. So that's what a little intro on cardio-oncology.
So, Dr. Medepalli, that was fascinating, and that was kind of a word to the wise for all of us. You know, cardiovascular disease is the #1 killer, and there's no time like the present for every individual to watch their blood pressure, their cholesterol, get moving. Certainly don't smoke cigarettes, but even before a diagnosis of cancer, wellness is a practice for life, and we've got to do it all the way through the continuum. It makes it a lot easier when they get diagnosed, unfortunately, with a cancer to continue those active lifestyles and to not have anything, like you said, draining the bank. Right. Is there any other special advice that you would give somebody about maybe seeing their medical doctor routinely to make sure that they know their cholesterol or their blood pressure measurements?
Absolutely. Very well said. The first part was very, very well said. That like participating in this, cancer community, support community. I get the emails. I also subscribe to this to see, how good our cancer support. Sometimes I give out to my patients the website. The issue is taking care of as a whole, anxiety, depression. Women especially have a lot on their plate. Could be single mom or postmenopausal, or the obesity setting in, less metabolism goes down. So taking the data supports that people who participate in exercise or rehabilitation program or in social circles like this will have less cardiovascular. They have a longer survivorship with the better quality of life. That said, keeping up with their physicals, knowing their numbers. The American Heart Association gives big 7, like A, B, C, D, E. We talk about awareness itself, being aware that they had cancer, or they are going through the cancer, or they're survivor of the cancer, or I have patients who have cancer since 2012, 2009. They're on maintenance therapy and cancer is under control. That's great. So even that is survivorship. So knowing their numbers, diabetes, blood pressure, cholesterol, smoking, diet, weight, exercise. So I give out every patient of mine at ABCDE. I call to their attention. You need to be aware of that you had cancer. Your heart has seen that stress. You need to get your blood pressure less than 130/80, and C is for cholesterol and cigarette smoking, and make sure you follow the annual physicals and get your LDL under control. D for diabetes, watching their hemoglobin A1C, and diets like Mediterranean diet and DASH diet are recommended by American Heart Association, and E for exercise. So those 5 things, along with social circle involvement as much as possible, will be excellent for their survivorship.
Right. And you showed that graph where all the new medications for cancer patients are just exceeding all the other cancer types. Unfortunately, some of those medications do have cardiovascular side effects. They may not be like an anthracycline and weaken the heart muscle, but they can raise the cholesterol, which is often the patient's not aware if they're not getting that checked routinely.
Absolutely. Yes, I agree.
Okay. All right. Well, that's great information. What more do you have to share with us?
So just speaking along the what you said just before, not just anthracyclines. In 1970s, that's what, the anthracyclines, if they got doxorubicin, the red medicine, the first article which came out in 1979, they used to do MAGA scans. They thought, okay, heart failure, that's all we need to watch out for, that's it. But later on, the HER2 targeted therapy, 25%, I guess, Cheryl, correct me if I'm wrong, the breast cancer patients are HER2 positive. good and bad with that. Good, excellent response. Bad is they need to keep up with their cardiovascular health. And almost all patients know that they are mandated to check their blood pressures, their echocardiograms every 3 months. And they're keeping up their ejection fraction and advanced technology, strain imaging these days to help predict ahead of time any complications. So the HER2-targeted therapy, Herceptin and associated drugs have heart failure as a risk, especially if they received anthracycline and followed by Herceptin. So we not only during HER2 completed therapy, we recommend another echo in 6 to 12 months to see if anthracycline had any remnant heart failure problem. VEGF inhibitors, the small molecule VEGF inhibitors, big problem. We are actively working to develop a program for Northside Hospital as well. Lots of 20 to 30% of patients within 10 days, the blood pressure shoots up. And with the blood pressure, it comes the problem of heart failure. And these VEGF inhibitors, mainly vascular growth factor inhibitors, the cancer cells need blood vessels, but by targeting the blood vessels and inhibiting the flow to cancer cells, the cancer is getting controlled all right. But all these kinases are also important for our own normal survival, cardiac and vascular homeostasis. So by inhibiting the blood vessels in the cancer cells, we are also off target. That means we didn't intend to do that, but it's off target effect on our own mechanisms for maintaining our blood pressure and cardiac health. Those are also getting affected. That is how we are getting off target. Target is cancer, off target is cardiovascular problems. So that is why we have to be very, very careful with VEGF inhibitors when they get initiated to check their blood pressures every week and, get to their primary care physician or oncologist or whoever their immediate healthcare providers are to take care of the hypertension, to avoid unseen consequences of heart failure, kidney damage, early dementia, and things like that. And in 2005, we have for multiple myeloma, proteasome inhibitors. That group of medicines came, and again, risk and immunotherapy exploded from 2010. And I hear that even metastatic cancers, any cancer can get this immunotherapy with very good response. And the immunotherapy, I think we have 8 to 10 now, right, Cheryl? With that immunotherapy.
Right, there are several different immunotherapies.
New ones. And they have this myocarditis and heart failure as a potential risk. The risk is low, like 2 to 3%, but if it happens, the risk, it's fulminant, the 50% death rate. So we need to patients need to know that what to watch out for. Even though it's 2%, they need to know when to call to the healthcare provider's attention, because they will be coming back again in 3 weeks for their 2-3 weeks, whenever the oncologists have said to come back. But in between, they have to watch out for shortness of breath, heart failure, dizziness, arrhythmias, and things like that. So this is where one area, and VEGF inhibitors, HER2-targeted therapy, and this is only a handful. Last night, I was going through some data. Over 20,000 cancer drugs are available out there, over 20,000. And we're not targeting each one of them. We are targeting the top 10 groups at least, the highest risk. CAR T cell therapy, when I round in bone marrow unit, I see few of those patients. The day 1 infusion is done, but then day 0 infusion is done, but the problems come 7, 8, 9 days later. We call as CRS, cytokine release syndrome. The blood pressure may drop, hypoxia. As a consequence of this, arrhythmias come in, and heart rate, atrial fibrillation, and few other things may come in. So we monitor for that in the inpatient setting. We get consulted all the time. And people who get chest radiation, abdominal radiation, and neck radiation, as we saw the graph, it's usually after 5 to 6 years we see the consequences. They may if a heart is in the field, valvular thickening, pericardial, the covering of the heart called pericardial thickening, and heart becomes more stiffer, called diastolic dysfunction. It's not of a weaker, it's more of a stiffer. So that can lead to heart failure too. And women already tend to we have a small heart, small arteries, already we take less steps compared to our male counterpart, and we are overweight and obese. If they combine together, women after 50 are more obese compared to men. So we have already these risk factors, and already we need to work on that. And then this radiation can worsen that. So stiffer heart, covering of the heart function itself, and valvular heart disease. So after 5 years, not only checking every year, as Dr. Jones has suggested, keeping up with your numbers with your primary care provider, absolutely important if you are exposed to these drugs. And ABCDE, keep your fingers all, blood pressure, cholesterol, diet, exercise, and keeping up with, after 5 years, start screening even for potential heart problems is important. So to summarize, anthracyclines, alkylating agents, these are different top 10 groups which I really focus. Dr. Jones just mentioned about certain drugs can cause elevated cholesterol, triglycerides. Those are endocrine-based therapy, especially with prostate cancers, and also with the ER/PR positive, the endocrine therapy related breast cancers, the cholesterol may go up. So hypertension, big problem, 20% big problem with prostate cancer treated patients with endocrine therapy, so GnRH agonists. So it is extremely important when you start the chemotherapy to check with your care team, oncology care team or support staff, and raise the question in your group discussions. And, this drug, what is that I have to watch out for, and taking care of that is important. So a picture again, so arrhythmias, not every drug gives arrhythmias. So certain drugs give certain problems. The platinum group of drugs can cause, accelerated atherosclerosis, a medicine called 5-FU or Xeloda, the medicine given for colon cancer can cause coronary artery spasms, chest pains. And, recently I came across a massive heart attack. When we checked in, arteries were completely normal. So with 5-FU. So it can cause intense spasms. So don't neglect the chest pain or anything. Write it off as, oh, yep, I had a spicy diet last night or something. You have to get to the attention. If it is something to do cardiovascular, it won't be just one and go. It will be haunting you. So don't click on, seek medical attention.
Well, that's fascinating. So a lot of these side effects from off-treatment side effects, as you described it, from chemotherapy, can happen not just when you start the medicine or within 24, 48 hours, like we think about with chemotherapy nausea or something like that. These can be developed over time and have to be watched continuously throughout the course of the lifetime.
Yes. Okay. Especially VEGF inhibitors, the incidence of hypertension is not right away. It is usually seen about 1 week. So that's why we recommend checking blood pressure if they are started on Avastin or VEGF group of inhibitors, imatinib or sunitinib and axitinib. And I have several patients coming across the border. They come first time, and then next time I do telehealth if they have a good blood pressure cuff. And we are going to try and see if Northside Hospital Foundation, we can provide that help, working on that with administrators and yourself involved. Thank you for that. And so very important to keep all the time. Once we get that cancer diagnosis, you have to find out what else is involved with this cancer, not only cancer, but also what did I get for my cancer and what are the potential side effects I have to watch out for, other than keeping that ABCDE nonstop in their mind.
So you do not accept the answer from a patient that they only get nervous when they go to the doctor's office and their blood pressure must be high because they're in the doctor's office. That's something we can't accept, correct? We have to keep watching that blood pressure throughout.
Yeah. There is very well described term called white coat hypertension. But if the patient is getting Avastin and the blood pressure is high, it's extremely unlikely just white coat hypertension played that role. So, but still, that exists, that white coat hypertension, extreme stress exists. So that's why we recommend checking blood pressure. And we do have American Heart Association blood pressure, how to take your blood pressure properly. We got permission from American Heart Association. It's in website. I'm not sure, Katie, if you can share that in CSE later on. We can, but Northside Hospital, we are working with Maxine and Jackie from NHHI and I wrote the top 10 things which we need to take a blood pressure properly on a pamphlet. So we're going to develop that as a Northside system and record that and put it in our website. So all our cancer patients, when they are requested to check blood pressure daily, they know how to do it properly. So it's a 2-minute short video. We are going to work on it next. But it's already there in American Heart. If you check on the YouTube too, how to take a blood pressure properly in American Heart Association, AHA or AMA website, it's there. It's free for public. So it's a just 2-minute video. So it is not only how we take blood pressure is very important, not just, I see all the time they wear thick sleeve sweater and then they check blood pressure on the top of it. They get, they're rushing, coming in, crossing their feet and sitting, talking, and then taking blood pressure. They have to follow also, the guidelines are written with 10 minutes sitting, empty the bladder, half sleeve shirt, on the bare skin, not talking, not crossing their legs, with a preferably back support like a dining chair and at the same level, and checking the blood pressure. Usually 2 times. The first time invariably will be high, and usually the second time, or if they can take an average or the second time is what we recommend to take it as their blood pressure. And then keep an eye on that if it is more than 130/80. And especially if they're getting VEGF inhibitors, a small molecule, the Avastin, axitinib, they have to start checking their blood pressure as soon as they get their treatment started. Sunitinib, axitinib, ponatinib, all these drugs. And then if it goes up, they need to call to the attention of the oncology nurse navigator or cardiology nurse navigator, or get to their primary provider, whatever it takes. I let the patient know, whatever it takes, it's between you and me. If you have to call 10 times, you call. I won't know unless I get the message, So you have to take control and you drive your car to the right direction.
Okay. And the goal is 130/80 is where you want the blood.
Yes, at rest. Yes, at rest.
That seems to be all the questions there.
Hey, yeah, labs on Rachel Johnson.
And can you tell us a little bit about the program at Northside, Dr. Medepalli?
Yes, that's what I was envisioning, and we read my mind. Our administrators have the same vision as you and me, and the several oncologists and cardiologists and support staff are looking for our cancer patients. It is astonishing to see the numbers Northside handles. Not only high accolades, the top, I guess, top 1 or 2 in bone marrow outcomes across the entire nation, United States of America, but also our Cancer Institute treated greater than 15,000 new analytical patients across the network in 2019, and that number is growing. So there are more than, we were trying to apply for gold certification, and we were very astonished to see over 46 infusion centers across Georgia and 50 cancer centers across Georgia, NHSCI handles, and they have most advanced treatment technologies available, active research going on. So this much happening in the cancer world, it only makes sense to have a good by-the-side support program for our oncology our colleagues. So the field will excel and take off and continue to take off. That's when the administrators also had the same vision, and oncologists like you and several others, and myself and several other cardiologists got together. And we kind of started a task force, Cardio-Oncology task force, initially in October 2021, January, and it now matured to we have an official Northside Cardio-Oncology program from January of this year. So our goal is to provide support and accelerate the access of the patient. If the oncologist thinks, okay, I need this patient's cardiology support, to accelerate the access, not as consult put in, it takes 3 months, 4 months, what have you, but they get rapidly within required time by the oncologist and improve the cardiovascular outcomes along with their oncology survival. So that's what we are trying to work together as a team, oncology, cardiology, cardio-oncology, and we have to add one more for administrators here and support staff. So the task force, what this is mainly our goal is to provide continuous and coordinated, consistent care. We want preferably to see before high-risk cardiotoxicity, especially if a patient is planned to be high-risk cardiotoxicity. We want to see them ahead of time rather than already cancer treatment started and some problem set in and see emergently for problem and not interfere with the oncology treatment. During treatment, of course, always, and early if they need, and right after their survivorship, especially high-risk patients like those 3 top priority who received anthracycline-based chemotherapy, especially more than 250 milligram per meter square lifetime dose, or chest radiation, abdominal radiation, or neck radiation, and allogenic bone marrow transplant patients. So that's why we also have a cardio-oncology program at northside.com. Navigator, Cindy Wilson, who is now our navigator, she's phenomenal and excellent. And our goal is to have a dedicated availability, improved accessibility, and easy scheduling. So oncologists like you, yourself, Cheryl, and several other even patients, if they want to have their cardio-oncology, they are fit into one of those categories, high-risk chemotherapy or blood pressure problems and things like that, they can approach their oncologist, they can approach their physician. And this is just an awareness program for you all. And thank you for logging in. Being aware is number one, ABCDE. A is for awareness. So that already starts helping your own survivorship. Or send a message to Cardio-Oncology program at northside.com email, or call between 8 to 5. I think she's available at this number, office number. So 8 to 5 weekdays she gets to this email, she will respond next working day, and then she can communicate with you if needed, be seen by a doctor, facilitating that communication with your medical doctor or getting us to one of us.
Okay, well, thank you. And this program, as you said, is envisioned, has already been accredited with one of the highest honors, one of the few in the country. So that's an amazing accomplishment. We've had some excellent questions come in, Dr. Medepalli, and I'm going to refer them. We've talked a lot about some of the chest radiation and the anthracyclines, but we have one from a patient who has undergone, several rounds of chemotherapy, as well as both chest and abdominal radiotherapy and immunotherapy. So lots of different treatments layering on top, and has an upcoming appointment with the cardio-oncologist. And their question is, what are some of the questions that they should ask, and be prepared to ask their oncologist so that they make certain they get all the best information with their cardio-oncology visit?
First, I always advocate for my patients to bring their medicines. They come to the doctor and think, oh, yeah, everything is in there in the computer. But we have so many different systems. They don't talk to each other. And unless we have the right, we don't want to, last thing we want to do is do harm. our main goal is do no harm first and then treat the patient. So I'm very reluctant to change any medicines without me absolutely seeing from physician's note or seeing the medicine bottles themselves, rather than sometimes they come metoprolol. Is it tartrate or succinate? I don't know, metoprolol. So, and there can be, it's important that they bring their medicines to their, and then blood pressure, keeping up their numbers, then they have their physical numbers, blood pressure, cholesterol numbers, the hemoglobin A1C numbers, if they have a anthracycline-based chemotherapy before, if in case, you have a patient had the doxorubicin in New York in 2001, how much did you get? I don't know, so first thing I write down if I see a doxorubicin-based patient is I write down their lifetime dose, as I know this is what you got this time, because the anthracycline doxorubicin is exponential. The risk goes up with the dose. So the higher the dose, the higher the risk. So they need to know their lifetime dose. So whatever information they have in reference to their, as the patient is mentioning, the question, what kind of chemo, doxorubicin or radiation or chest radiation, or how many cycles, or what are their numbers and what are their medicines. Sometimes they take pictures of all their medicines and bring me, that's fine too, or bring their bottles. And if they can check their blood pressure at home periodically and bring those numbers to us, because we just, as you said, it could be white coat hypertension. So we don't want to jump the gun and raise the medicines quick when then they go home and take all their medicines and it drops. So, and sometimes I see patients coming in, I'm in a hurry, so I didn't take my blood pressure medicines today. So if the blood pressure is high, I cannot adjust the medicine, so I just let the patient know, pressure to take your medicines, even if you don't have nothing to eat, just eat an apple or get an oatmeal. Don't wait for preparation of your so that way when you come to me, what medicines you're already on, this is what I have to work with. If it is low or high, or I need to adjust your medicines. If you don't take your medicine and come, I won't have much room to up or down, so we don't want to overtreat or undertreat the patient. So these are all very important, just to blood pressure cuff. Sometimes if they have a blood pressure cuff at home, they can bring it once in a while. So they check and we check and make sure it's within 5-10 millimeters of difference, standardize it. So that will be also helpful.
Okay, so their current medications, but also any treatment history. So any chemotherapy medication that they may have had, even if it was many years ago, and likewise radiation many years ago. So not just radiation to the chest or heart, but abdominal radiation, if we know approximately what area, because of the renal arteries and other anatomy that's close. So
right.
Any information is helpful. Great.
Yeah.
Great.
Or neck radiation too. I had one patient having dizzy when she had the patient had a cancer on the lower part of the tongue. She did receive the radiotherapy. So when we scanned, there was carotid vascular disease type. The artery going to the brain may get exposed to the off-target effect again. So it is important that what they had before, it depends on the cardiovascular risk factors, what chemotherapy or cancer therapeutics, chemo or radiotherapy or immunotherapy, and what do they have already? History of heart attack, heart failure, arrhythmias, valvular heart disease, the pre-existing cardiac.
Yes,
right.
So cardiac history includes all the vessels.
Yes.
Mm-hmm. Now, there are several. Cardiology is such a broad field, and there are a lot of cardiologists. As a cardio-oncologist, so a specialist of a specialist, you work with individuals, local cardiologists, because
yes.
of the unique extra interaction with the oncologist. How does that work?
I have several patients who have their cardiologists locally, and especially with allogeneic bone marrow transplant and things like that, they come from other states and stay right down the road to the hospital within a for 2-3 months and things like that. So they come and see me pre-transplant evaluation, even though they had a cardiologist there, because things happen after bone marrow transplant. Lots of times things happen. So our oncologists want, people, cardiologists who knows the patient and get on it right away. So I have, several oncologists also send patients from cardiologists as such, in Stockbridge area and other areas. I'm in communication with them. They send the patient for cardio-oncology, and then once in 6 months, they keep seeing the patients and do the whole health, cardiovascular health. Just in respect to cardio-oncology, I see once their treatment is done, the survivorship, I will write down, you need to do this for your cancer treatment is all done, survivor, but keep an eye of all these numbers. And you need echo every 5 years for radiation therapy and things like that. So I give them some guidance, and I send my note to the cardiologist. And we work very well. Several cardiologists know that there is cardio-oncology specialty who knows to jump on certain drugs very fast and rapidly.
Right. And we have several drug questions that I might just jump in on you. Is that that Keytruda is a immunotherapy, is also considered a checkpoint inhibitor, and that with adriamycin or doxorubicin, there are some infusional medicines that we can give to try and reduce the toxicity. It does not take it completely away. The addition of a statin really is only helpful when the patient has a high lipid levels or cholesterols, that just taking a statin for an anthracycline will not reduce its potential long-term effects. But another question with this program is, as you mentioned, that there is a navigator and a patient can self-refer to the program. They do not have to be a Northside Hospital Cancer Institute patient to see a cardio-oncologist at the institute or need a referral, correct?
Yes, they can certainly send an email to, I had previous talk, several Cindy Wilson sent, got the email or phone call, and we have several cardio-oncologists. We are about 14 or 16 in Northside system, so they don't have to specifically come all the way here to Atlanta. So if they live in Canton, we have doctors. We have in Northside, Forsyth facility, we have. So she can connect. If they need a referral, she can refer the patient to get your medical doctor, that refer, or some doesn't need a referral, or she can just make the appointment for them.
All right. So these have been a lot of information has been available today, and this information will be continued on the Cancer Support Community website. They have taped this program for review for anybody that wasn't able to see it live today. But please feel free, and the contact information is up on the screen right now. And Katie, we'll turn the program over to you.
Thank you, everybody. Thank you, Dr. Medepalli, and thank you, Dr. Jones, for coming back. This was a lot of great information. As a reminder, I think Dr. Jones just said we're going to have a recording of today's program up on our website, and we will also have a complete list of all of our programs there, so you can see some great virtual programs and some in-person programs taking place. You can get all that information, and that's cscatlanta.org. So as we wrap up today's program, I'm going to throw it out to you, Dr. Medepalli and Dr. Jones, for any kind of final thoughts to close us out. Dr. Medepalli. Go ahead, Dr.
Cheryl. My thought is that, it is so rewarding to have the support of a cardio-oncologist. I obviously every day have the work to tell patients, that they have cancer. I have the joy to tell them when they're in their survivorship, and, the hope that they have from all of these new therapies. And so I certainly, am thrilled to have a cardio-oncology partner to make certain that their quality of life and survivorship will just be maximized as we go into the next century. So,
absolutely. Yes, absolutely. With the wonderful cancer outcomes and care Northside system has, We are so glad to be a part of the cancer therapeutics team, just as a support team from cardio-oncology field as well, from Northside system.
Thank you both again. You're always so generous with your time and expertise, and we greatly appreciate all of your support. Thank you, everybody, and we hope to see you soon. Everybody take care.
Bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.